Consumer Education webinar series. My name is Chris Palmer. I'm the director of the series and the director of continuing education here at McLean Hospital. Today we're going to be joined by Dr. Igor Weinberg, who is a psychologist here at McLean Hospital and an assistant professor of psychology in the Department of Psychiatry at Harvard Medical School. And he's going to be speaking with us about the comorbidity of borderline personality disorder and substance abuse. Before we get started, a few logistical announcements. All of your microphones and your identities have been, your microphones are muted and your identities are not visible to other participants. But we do want this to be as interactive as possible. In the lower right-hand corner of your screen, you'll see a Q&A box, and you can type in questions there. If you've come to this webinar with a specific question in mind, you can even type it in right now, and we'll put it in queue and get through as many questions as we can at the end of the presentation. In the lower left-hand corner of your screen, you'll see a lot of web resources. That first link is to all of our webinars, and it's our webinar homepage. So if you're new to this series, you can click on that link and you'll see all of the archived webinars. You'll also see registration links for upcoming webinars, and we have many webinars scheduled up until June right now. So you can feel free to pre-register there. That next link is for our January 25th webinar. And then the next three links are for national resources on borderline personality disorder. So if you're looking for a clinician in your area, you can go to any of those sites and look for information. The Borderline Personality Disorder Resource Center in particular has a national hotline phone number that you can call, and they have some referral information. So if you're looking for a clinician, you could try them. And then finally, these webinars are brought to you for free through philanthropic support by a family who has also been affected by borderline personality disorder. And if you are in a position to be able to help support these webinars and help them continue on, we ask for your support, and there's a link toward that bottom of the page that you can click on. And without further ado, I'm going to turn the webinar over to Dr. Weinberg now. Thanks.
Good. Thank you very much, Dr. Palmer, for this wonderful introduction. So I will be talking today about the relationship between substance use disorders and in borderline personality patients. Specifically, I will be talking about different aspects of this, but also going to be talking about treatment. And by the end of the conversation, I will also give some guidelines what families should know in terms of intervention, because sometimes families have a role in intervening. And next slide. I don't have a conflict of interest, as you can see. I would like to start with a few myths that are very prevalent in the field, and it's really both in general public, but also among clinicians. Many times we find that even clinicians sometimes think that those statements are somewhat true. And I just wanted to start with this, and curious if any of you can resonate with them, and if you do, we can leave some of the discussion of your reactions when we get to the questions at the end of the talk. So the first myth that I usually hear is that all borderline personality disorder behaviors result from substance use, and it's enough to treat only substance use disorders, and then all the behaviors associated with borderline personality disorder patients disappear. And of course, this is in people that have both substance use disorder and borderline personality disorder. We hear this a lot, but we don't find research support for this type of a statement. Those studies that looked at the interrelationship between two disorders found that both of them are valid disorders, and they can actually make each other worse in one way or another, but they're not creating each other. So we can't quite say today that substance use disorder can really produce symptoms of borderline personality disorder. And the implication of this, of course, is that both of them require treatment. And here's an opposite statement. I already anticipated this with some of the information I shared. The second one is that all substance use behaviors result from borderline personality disorder, and that means for some people that it's enough to treat just borderline personality disorder without additional focus on substance use disorders. And that's a very optimistic statement. Some people feel that it's just enough to treat one disorder and others disappear. We do know that it's true about some of other conditions that comorbid with borderline personality disorder. For example, a lot of the depressive symptoms go away when borderline personality disorder gets better. But that's certainly not the case for substance use disorders. They're really two independent conditions, but also interrelated. Substance use disorder occur completely independently of borderline personality disorder. That means that those are independent conditions, they have nothing in common. Sometimes people want to propose it thinking that, they can just treat them almost with two different providers, for example, and as if it's really possible. And I think the truth is that we are all complex people. We have different sides to us, and we can't imagine that things can be compartmentalized in such a way that people can have two conditions that are not influencing each other. And actually, I'm going to demonstrate in the next few slides how those two conditions are, in fact, interconnected. And that's significant for understanding, but also for treatment. Another myth is a little provocative in the way it's phrased, but sometimes I hear it because that's how people think about it. So this is what it says. Borderline patients are manipulative and lack discipline, and they need to learn self-control, and in that way they can stop substance use. So it's as if they can just knock it off by just getting better self-control. This is very, very far from how the reality is, but it's unfortunate that sometimes people think like that, and it really begets a lot of negative judgments. Here's a couple of other ones. So there are no specialized treatments for substance use in borderline personality disorder patients. It's more of a hopeless statement. Some people said once you have it, there's no specialized treatment. You just have to figure out how to stop. Maybe you have to go to AA. Maybe you have to figure out how to stop on your own. Maybe you can try some generic treatments, but there's nothing specialized. The truth is that specialized treatments have much better outcome when it comes to treatment of patients with borderline disorder, and especially borderline personality disorder with substance use. And in fact, there are some pretty good treatments that help decrease substance use in borderline patients that were specifically developed for that population. So that's actually quite hopeful. And here's an opposite statement that we actually hear also a lot, and it's also not accurate. So it says there are no treatments for borderline patients while they're still using substances. They need to stop using first. So here's a paradox. We're saying, well, you need to stop using first, but you're using substances to deal with borderline personality disorder. So actually, it's hard for you to stop before you address borderline personality disorder, but we can provide you treatment for those things. You really need to stop first. So that really creates a catch-22 that the person is not able to stop using substances without addressing borderline personality disorder, but we cannot provide services to address borderline personality disorder because they're still using. And that's a real conundrum. It's a challenge when people feel that they cannot treat patients like that or cannot provide services. It creates a really large number of patients that seemingly cannot be treated with this type of philosophy. The reality is quite different. The reality is that both substances need to be addressed together. They can be addressed together, and there are really good treatments that do that. I can move to the next slide. Just to give a picture of how prevalent those conditions are, this is figures of prevalence, meaning how frequent those conditions in general population, and also what is the frequency of occurrence of those conditions, just to give a picture about the significance of this clinically, but also in general. And so we find that about 27% of patients with substance use disorders, so people that are using substances and meeting criteria for that to be a disorder, meaning that it's not a recreational casual use, but it's a serious use that is chronic, when people have trouble stopping, when it's affecting their functioning. So 27% of people like this also meet criteria for borderline personality disorder. So it's a little over a quarter. And that's a significant number. You think about it, by comparison, borderline personality, it's one of a number of personality disorders. It's not the only one there, but it's more than a quarter of people with personality disorders. So more of the quarter of people with substance use have borderline personality disorder. So it's really overrepresented among other disorders as a prevalent condition. Now, if we look at the reverse statistic, how many people with borderline personality disorder have substance use disorder, it's a very large number. We find that 57 to 64%, so really more than a half of patients with borderline personality disorder have current substance use disorder, meaning at the same time that we're looking at them. And if we're looking in a lifetime prevalence, meaning if they met criteria for substance use disorder at any point in their life, so they may not even meet criteria today, but if historically they met criteria for this, they're certainly going to be in that group. We find that 78% of the patients. So it's a very large number. So majority of patients with borderline personality disorder also either experienced or have experienced troubles with substances at some point in their lives. And you're going to be surprised if you find with the following finding that when people have substance use disorder, when people have borderline personality disorder, the chances of having substance use disorder increases by 450%. Okay, so that's a significant increase, very, very significant increase. So meaning that people with borderline personality disorder are much, much more vulnerable to also have substance use issues. So those are quite overwhelming statistics if you think about it, but really talks about very, very close connection between both of those conditions. And therefore, there is an important question that we will address a little later, how we're going to address them, and also what's the reason that there's such a close connection. And the last finding here on this slide is that borderline personality disorder is the second most common personality disorder diagnosed in substance use population. Number one in terms of frequency is antisocial personality disorder, which historically was always the case, and BPD is the close second. If we can go to the next slide. So maybe some of the common problems that we usually find in this population, and that's important because that really, again, emphasizes that this is a population that really is in very, very dire need of treatment. So this is a group of patients. So again, we're talking about patients that have both borderline personality disorder and coexistent substance use disorder at the same time. That is the group. So what we find is that they have early onset of symptoms. So they start experiencing difficulties early in life. They have much more severe dependence on substances in terms of withdrawal, in terms of difficulty stopping, et cetera, and amount of substances that they're using. They have lower level of psychosocial functioning, which has to do with social functioning and keeping a job, for example. They're much less likely to function, essentially. They have much more frequent use of other drugs, meaning they're much more frequently using more than one substance at the same time, what used to be called polysubstance use. We don't use that term anymore, but it really captures the issue. They're at much higher risk of suicide, and not just suicide attempts, which should not be taken lightly anyway, but we're talking about suicide completion. And they're much more likely to relapse and less likely to stay abstinent. It's more difficult for them. One of the theories would be that personality disorder makes it much more difficult for them to stay sober. Those are also the patients that are less likely to stay in treatment and more likely to drop out. And of course, such course of the disorder is really associated with persistence of both conditions and health problems, but also legal problems, which usually come at some point in the course of substance use. So there is a reciprocal effect of substance use and borderline personality disorder. So if you remember, there was a myth that those two conditions are independent. That's not exactly the case. They're interrelated. That certainly becomes part of the philosophy of treatment that you have to address both at the same time. So this is some of the findings. So that the borderline personality disorder is associated with persistence of substance use disorders. Usually, as long as borderline personality disorder is active, it's not in remission, people are much more likely to continue to use. And the other way around, when people are going in remission in terms of borderline personality disorder, which happens actually with regularity and much more frequently than we used to think at least 20 years ago. But today we know that borderline personality disorder patients go into remission. So when they go into remission, also substance use disorder go into remission. That's important to remember, more likely at least. And it's important to remember that persistence of substance use disorder is better explained by personality disorders, including borderline personality disorder, not by mood or anxiety disorders, which is to say that a lot of times we have patients that keep coming with frequent relapses. So they keep relapsing on substances, and sometimes we ask ourselves, what's the reason that they keep relapsing, not getting better? And many times the reason for that is that they have borderline personality disorder or sometimes some other disorders, and unless that disorder is addressed, they are likely to come back with more relapses. But they have much more favorable outcome if borderline personality disorder gets addressed and gets treated. Also, studies indicate that there is a seemingly there is an overlap in vulnerability. So both disorders have some type of vulnerability that may be genetic, may be developmental, but for whatever reason, people have a common vulnerability factor that is likely to contribute to development of either of those disorders or both. Okay. Maybe next slide. So sometimes people ask about the function of substance use disorder and borderline personality patients, and there are a lot of theories about this. And it's important to remember that the same behavior is likely to serve a number of functions, and that makes treatment more complicated, and that's why the treatment requires more attention in that area. So studies demonstrate that substance use in borderline patients is likely to be associated with every sector of psychology of borderline patients. So we're talking about one, probably the most well-known sector has to do with emotional dysregulation. So that has to do with substances regulating emotions. This is a theory that has to do with the substances being a form of self-medication when people trying to regulate emotions. I'll talk a little bit more about this in the next slide. Impulsivity, that says that people that more impulsive, and a lot of people with borderline personality disorder are impulsive, who engage in impulsive behaviors. They are more likely to engage in other impulsive behaviors because they don't think about consequences, or because those behaviors feel like fun or thrilling. And therefore, that becomes a vulnerability factor. Or interpersonal instability. A lot of people with substance use use substance to regulate attachment, either because they don't want to feel abandoned or alone, or dysphoric when they feel separation from others, or because this is how they address their interpersonal needs, essentially. A lot of the people with substance use disorder, and also among patients with borderline personality disorder, display what's called avoidant attachment, which associated with regulating distress, usually by avoidance. And that many times that puts people at risk because substances become a very quick way to regulate distress through avoidance, not through attachment seeking. I apologize. And the last one has to do with identity diffusion. So one of the criteria of borderline psychology is having very conflicted and confusing ideas about who people are. And that it's a very actually uncomfortable experience. Thank you so much. And with that experience, many times people feel confused and torn among very different directions, sometimes quite opposing directions. And more than one patient told me that the substances sometimes become very quick fix for this internal confusion. So instead of resolving those internal conflicts and confusions and thinking them through and putting them together, essentially people say, I don't want to deal with this, I'm just going to use substances. And that doesn't really solve the confusion. So this is the next slide. So that's probably the most famous theory about the function of substance use. It has to do with what they call self-medication hypothesis, which has a lot of support. And we do find that people with borderline personality disorder are more likely to use substances to feel good or to seek excitement. Okay? And the idea is that sometimes people match the substance that they are choosing to the mood that they're trying to regulate. The extent to which it's really accurate and explains every case may be debatable, but it's a nice way to think about it. So the theory about this would say that people that are increasing low arousal affects, for example, depression or shame or sadness, are more likely to use substances that are increasing arousal. They're trying to upregulate the arousal. And those would be, for example, amphetamines or cocaine or some hallucinogens. In some people that are experiencing high arousal affects with high arousal, such as anger or anxiety, for example, they're more likely to use substances that will decrease their arousal, for example, alcohol, cannabis, or opiates. So the clinical challenges that we have is that because we seemingly we have a very strong case that this is a population is really in dire need of treatment. And I hope that my slides make a case for that. But then we have clinical challenges. How do we treat people with this comorbidity? And this is for the following reason. So a lot of the patients with borderline personality disorder are commonly excluded for randomized controlled studies for patients with substance use disorder. So when we're trying to test what treatments are effective, the gold standard for this is called randomized controlled studies, when we are usually using two different groups, sometimes a little more, and we're comparing effectiveness of two different interventions. And when we're conducting studies like this, a lot of times researchers producing different inclusion-exclusion criteria are saying what type of patients can benefit from the treatment or not. And what we usually find is that a lot of researchers want to focus on the very restricted population of patients, and they exclude people with substance use disorders because they feel it's going to be too heterogeneous, the differences will be too large. But the same is true also for studies for patients with borderline personality disorders. So we see that people with borderline personality disorders usually excluded from studies of patients with substance use disorders, treatment for them. And when we study treatment for borderline personality disorder patients, a lot of the studies exclude patients with significant substance use disorders, again, for the same reasons. They want to create a much more homogeneous sample. There are some statistical reasons to do that. So that's artificial, and we know that doesn't reflect clinical practice. And some of the reasons also have to do with the following, that patients that have both conditions associated with high dropout and poor outcome of therapy, including psychotherapy. So sometimes people say it's very risky to include them in a research sample because you may have very few people left. And again, that means that we don't have a lot of clinical studies associated with investigating what treatments will be actually effective, if we can skip to the next slide. However, we do have a number of studies. So a few years ago, I decided to undertake an empirical comparison of available studies that were supported for treatment of both conditions of borderline personality disorder and substance use. And so I decided to search the literature in the most exhaustive way in which I usually do that, which I usually use all the engines for search, and then I looked at all the publications that were referenced in those studies that I found. And ultimately, I found three different studies. Well, we'll talk about this in a second. And so the idea was the following, really, to look at to identify the protocols for treatment of borderline patients with substance use, and then investigate those protocols on different interventions that were used to promote change towards sobriety and also towards less symptomatology in terms of borderline personality disorder. And so what was done is that we used the therapy intervention assessment scale, which was used in previous investigations. So at this point, it's an established scale to do those type of ratings. We can go to the next slide. So one other detail. So we had a number of clinicians that independently looked at those manuals that were identified and produced ratings based on that scale. So which is that's probably the most stringent way in which we can investigate those manuals at this point. And so there are three different treatments that were supported empirically. And so the first one is DBTS, which is dialectical behavioral therapy for substance use. And it's a standard DBT plus new modules that were specifically developed to deal with substance use issues. Essentially, there are specific module how to deal with cravings, specific module how to deal with saying no to people when they're offering you drugs. So it's what they call refusal skills. And a number of other things. Also talking about dialectical sobriety, which is an important concept. It doesn't exist necessarily in standard DBT, but when DBT was extended for the population of people with substance use disorders, they added also this concept of dialectical sobriety, which is very, very helpful. Another therapy that was tested, it's called dual focus schema focus psychotherapy. Schema focus psychotherapy was developed by Jeffrey Young. It's a sort of a amalgam of CBT, cognitive behavioral therapy, Gestalt therapy, and object relation therapy, and sort of that were put together in this package that's supposed to address what's called schemas. Schemas are different internalized assumptions about self and others that people usually develop through close relationships early in their childhood, and so what therapy is attempting to do is to help people change those assumptions, but also change how they cope with those assumptions, and it has some effectiveness. And it also was specifically tested for substance use disorder patients with personality disorders, was found effective. And then there was this therapy that was called dynamic deconstructive psychotherapy. And first when I read that title, I said, what are you talking about? What is that name? And it's actually very creative development of psychodynamic psychotherapy that was applied specifically for a population of people with substance use, with alcohol use disorder specifically, and was also tested with some promising results. Let's take a look at other slides. So those are the commonalities. It's a very busy slide, but we're going to spend also a little bit of time here. So if you're worried, not seeing some of this information, I hope we will spend enough time here. So what we found in that study with my colleagues is that there are a number of common factors among those three therapies. And remember, those three therapies are quite different. Okay, so we have DBT, which is a behavioral therapy, which is, we have schema-focused psychotherapy, which is more on the cognitive side of things, as a CBT. And then we have psychoanalytically, psychodynamically oriented psychotherapy, which also was promising. So those are quite different therapies. But we found that there are a lot of commonalities among those therapies. And so those are the commonalities, and they kind of make sense. So when we looked at them, we kind of thought, well, it kind of makes sense that those things would work for patients with both conditions. So the number one thing that we found is what's called dual focus, which is monitoring of borderline personality behaviors and substance use behaviors. So the therapy is essentially maintaining dual focus on both conditions at the same time. So that's important. So it's not that one is important, the other one is less important. Both are really equally important and are very important to pay attention to both. The other thing was that relapses are anticipated, so meaning there is a discussion of relapses, and there is a plan how to deal with them, and there is a plan how to deal with urges to use substances. In all those treatments, substance use is seen both in terms of behaviors and state of mind that contribute to them. So it's not just a behavioral aspect of substance use. It also has to do with thoughts and feelings and different distortions that contribute to that. all those treatments advocate use of exploratory interventions. For example, when people relapse, those relapses are followed by detailed chain analysis and problem solving, and usually those are the treatments that encourage curiosity of the patient about their state of mind. And another interesting finding was that in all those treatments ultimately encourage people to stay abstinent and not use, but they're not requiring that from the outset of treatment because they understand that it may take a while for people to fully give up substances and develop skills to essentially stay sober. Treatments do not see relapses as failures, but really think about them as opportunities to problem solve or learn, so it's a learning opportunity really. All treatments advocate for change-oriented interventions, meaning that they challenge maladaptive cognitions, they make lifestyle changes or identify alternatives to substance use, so they're proactive in that way. And they're also proactive in addressing treatment-interfering behaviors, for example, avoidance of poor attendance, which are very common. And also there is a special emphasis on what we call strengthening alliance. Alliance with the therapist is usually one of the strongest predictors of outcome, but also this is also the population that has trouble developing strong alliance. So, and usually there is a specific focus on that area because we really want people to stay in treatment. We want to make treatment as rewarding and as inviting as we can because we really have to compete to some extent with how substances are inviting and appealing to people. And also we have to balance the challenging aspect of the treatment. We're asking people to give up something that gives them immediate satisfaction or reward. So that we're trying to strengthen alliance through validation, education, collaborative goal setting, limit setting of destructive behaviors, and sharing case formulation. So we talk to people about what we think about them. And another aspect is a clear treatment frame. People know when sessions will be happening. There is a schedule. It's very well known, how long those sessions will last, cancellation policy, fee policy, and things like that. And also there are a number of things that are unique to different treatments. Because they're unique, it doesn't mean they're not helpful. It means that they were incorporated in different protocols, and they were helpful in those protocols, but they were not universal. For example, some treatments advocated for independent drug testing, like urine testing, for example, or use of pharmacotherapy, using specific medications to address substance use, or phone coaching. DBT is very strong on suggesting that phone coaching is important. Other therapies may not suggest that. And group therapy. Some treatments suggest group therapy, other treatments don't. So that's a busy slide, but those are the findings. It's really, in a nutshell, distill some of the central principles of treating that population. Okay. And that may be an example of crisis coping plan. So when we're talking about having a prepared or anticipated coping plan, this could be an example. This is not something I'm saying this is magically going to work for each person that's going to use it, but that may be sort of just an idea of what some people come up with. Okay. And you can see that the treatment plan is based on steps. So there are different steps of kind of line of defense. That's some of the metaphors, at least I use with my patients that I talk about them. We want to give you as many forms of protection as we can, and different steps in this plan become different lines of defense, so to speak. So you could really protect yourself. If the first line of defense is failing, you can use something else. Okay, we just had a screen that disappeared for a second, so thank you very much for putting it back. So we can go through this quickly. Those are just really examples, and again, there are numerous skills that can be used. Those are just very specific examples. So the first step could be using some distress tolerance skills, such as a warm bath or slow breathing or grounding techniques, or playing with pets, Next step could be using self-encouragement, reminding yourself, for example, that things will pass, that cravings will pass, and that the person was able to tolerate pain in the past, so the pain will pass as well. Those are really powerful statements that sometimes give people enough hope to withstand emotional pain, but also craving. Next one could be the step 3 would be reminding consequences of using, for example, thinking through what will happen. Sometimes people forget about this or minimize the outcome, thinking about hangovers or shame or feeling trapped by substances, etc. And it could be also going to a meeting or calling a sponsor or calling a therapist. So this is something that people usually develop collaboratively with their therapist, and the hope is that they can use it in a moment. They can also practice it. Practice sometimes increases chances of using skills in a moment. So if we can go to the next slide, would be great. Thanks. So maybe we can talk a little bit about family involvement. I have a couple of slides that I just wanted to give some guidelines, because a lot of times people say, so what can we do? And this is a little bit in that, so this is a little bit of along those lines. What can be done? What can family do, and maybe what they shouldn't do? So we also have some ideas about what is helpful, what is not. So therefore you see that family involvement do's. So this is the part of what is usually helpful. There will be a slide about don'ts, things that we usually find not helpful. So we usually emphasize that management of sobriety is always the responsibility of the client, not the family. Only the person has the full capacity to use or not use, but family sometimes has a role in it. It may or may not have a role. Sometimes it has a role, sometimes it doesn't. It's important to know, if, for example, if family is involved in crisis plan or not. If they're not, that's probably a decision that was reached with the therapist, and that's fine. So usually when there is a crisis and the person is about to relapse, it's important to encourage the person to use the coping plan. And if the crisis subsides, that's fine. But sometimes the crisis does not subside, and then it's important to encourage the person to contact the clinician or contact the sponsor or use any type of services that are usually agreed upon in that plan. So it could be a clinician, could be emergency room, sometimes it is, or it could be calling a sponsor, okay? Usually it's important to provide validation and support, and the validation can go really long way, and you're really validating what's valid. We usually tell people, don't validate something that's not valid. Don't agree with things if you think it's not true. But if you really think that the person is experiencing significant distress, it's usually important to say that you understand the person going through something really painful. You can suggest using a crisis plan or attending a meeting or calling a sponsor. So it could be kind of a nice reminder, but I would not necessarily insist on this. I would just remind that that's a possibility. But it's also important to be clear about your limits and consequences of using. So a lot of times people say, so what can we do? So sometimes the most powerful intervention actually is stating your limit. It's important to state those limits before the crisis happens. So make an agreement about those limits before the crisis happens. For example, if you relapse again, maybe you're going to have to move, not maybe, actually. If you relapse again, we would like you to move into a sober house. And if you relapse again, we would like you to sign up for a day treatment program. And then if the relapse happens, then there is an agreement. It could also be a written agreement. Okay, the next slide. And then this is a list of don'ts, things that don't really work, and we don't suggest for people to do. Manage relapse yourself, like doing therapy. We usually say leave it to the pros, in case this is really true. Because many times it actually invites enabling or rescue responses, and rescue responses many times are exhausting for the family, but they're also enabling or rewarding for the patient. They may actually precipitate next relapse. We're trying to do psychological assessment. How high is the risk? Assess risk of relapse. It's usually very hard to do it unless you're trained to do it, and usually it's easier to refer back to the crisis plan. We'll start suggesting coping skills beyond what's been suggested on the crisis plan, for example. or invalidate the person, nag or plead, that usually doesn't work. Blame or criticize. It's interesting when I read it, what's occurring to me is that so many people told me that, in fact, this is the first instinct. They know they shouldn't do it, but when the crisis comes, this is the first instinct. This is what they want to say, many times out of desperation, hoping that something will help the person to move in the direction of some productive coping. And yet we've learned that those are exactly the things that don't work. So getting angry or threatened with things. So unlike limit setting, which is just a reminder of this is the limit, this is what I can tolerate, threat is usually not anticipated in advance. It's not something that was discussed, but it's really announced as a threat. Or turning yourself into helpless victim, or dwell on the past substance use, or make negative predictions. So those are some of the common things that people do, and it's very, very universal to do it. It's not something we think it's not natural to do. It actually takes a lot of practice to not react in this way, but those are also not helpful responses. And I think we're getting into discussions and questions.
Great. Thank you, Dr. Weinberg.
Thank you so much, too.
If people have questions, feel free to type them in. We already have several in queue.
Okay.
So the first question is, could you speak a little bit about what substances are most commonly abused or misused in borderline personality disorder? Are there any statistics on that? Are there any common patterns?
It's a very, very good question. I don't have a statistic that I consider as a percentage. I don't think it's radically different from substances in non-borderline personality disorder. It's also something that is very affected by, what people are using today. If you look at statistics like 10 years ago, it's going to be really different from what's happening today. I do not think it's radically different from what's happening in non-borderline patients.
Okay. So alcohol and
cannabis and opioids.
Cannabis and other ones. So that leads into another question.
Yeah.
So on cannabis.
Yeah.
With the whole medical marijuana movement,
Yeah.
and a lot of patients with all sorts of disorders, including psychiatric disorders, believe that cannabis might help their disorder. What, if anything, do we know about cannabis use and borderline personality disorder? Can it sometimes be helpful? Is it usually harmful? Are there any patterns or trends?
It's a very good question. What I do know about this, there are no empirical studies that cannabis is effective. What is truly the case, and that's where I usually ask people to think about this again, is if you remember, there was a slide where I was talking about common vulnerability factor. Common vulnerability factor means that when people have borderline personality disorder, they also have vulnerability to develop substance use disorder, for a variety of reasons. Again, we don't know yet if it's genetic or developmental or environmental, but they're more likely to develop a disorder, not a recreational use, a disorder, meaning persistent use that with dependence on the substance, psychological or physical dependence or both, with a lot of difficulty stopping when the consequence of using the substance is far, far beyond what could be anticipated if we're talking about some benefits. And so that's very pertinent to this discussion of cannabis. So we don't have studies that demonstrate that it's effective, but we do know that there is a high risk of becoming dependent on that substance. And that's something people should keep in mind.
Okay. And another question is, are you aware of the influence of gender on the frequency of substance use disorder?
Mm-hmm.
Any trends in terms of men or women, boys or girls being more likely to abuse substances?
Gender differences usually are such that the raw gender differences, men with borderline personality disorder are more likely to develop substance use disorder, which is similar to the general population, that men are much more likely to develop substance use disorder and gravitate in that direction. Women are much more likely to gravitate towards developing depression and some other conditions. So I guess that answers the question, which is men are more likely to develop substance use disorder.
Okay. And so one just one piece of information that, if I can chime in maybe, is that over the last decade or two, my understanding is that that gap between men and women is closing, kind of closing rapidly, that women are tending to start using substances earlier, and they're becoming more like their male peers. But in older generations, that was absolutely true. But in the very young generations, women are almost matching men in terms of their rates of substance use.
That's important to remember. I guess it's also a question how you find those samples. I mean, if you look at the samples in the general population, that's may be the case. I think that what we find in clinical samples, when we look at the borderline samples, in those samples, usually the pattern that men are more likely to develop substance use disorders.
Yeah,
that's an important statistic.
So one question that has come up a lot, you talk about the clinical conundrum of a lot of treatment centers or clinicians who will say, well, until you stop using substances, I can't treat you. Or, until you get help for your borderline personality disorder, I'm not dealing with your borderline personality disorder. And I've certainly heard of cases, and through this webinar series, we've actually had a lot of people express concern about that people with comorbid BPD and substance abuse have been kicked out of substance abuse programs for being quote-unquote manipulative or too demanding. And likewise, BPD specialty clinicians have refused to work with people who are actively using substances and say, well, go to some detox or go to some recovery program. And so for the people listening, not all of them are here in Boston, and I know we at McLean Hospital have some programs that will definitely treat people with comorbid disorders, but then there's the rest of the world. and what are any practical advice for what they should do if they're having that dilemma?
I think the dilemma is such that it's hard to find people that are trained and willing to treat that population, but they exist. So it's a matter of looking for people that can take on a patient and they're willing to work with the patient within that model. The truth is that it's actually a very frustrating situation that people do have that reaction, that they say, well, I cannot treat it. But it also could be an honest reaction when they're saying, I don't have the skills to treat it, because that's another thing that could be happening. I guess it's a work in progress also of educating clinicians in the community about what can be done about this issue.
Okay, good. The next question has a few different components. So let me start with the first one. Is there a specific type of therapeutic environment or treatment setting that you think is most effective for borderline personality disorder with comorbid substance use disorder, like residential treatment, outpatient, intensive outpatient, and how do you think about which level of care is most appropriate?
That's a great question. I can probably give a talk for another hour about this decision. But in general, what I have to say is that the three studies, or three treatments that I quoted, were all tested for outpatient level of care, meaning relatively minimal treatment with maybe a group and individual therapy, or maybe just individual therapy, 2 individual appointments a week. So those are things that are usually considered outpatient treatment. I think that it really depends. It really depends on the level of the functioning of the person and degree of the risk of substance use and some risk of engagement in other conditions, in other behaviors. And that's usually the decision that we make between residential level of care or maybe inpatient. Usually inpatient level of care would be reserved to the detoxification when it's necessary, or when people are at high risk for example, for suicide. Residential treatment is likely to be appropriate for people when are very likely to relapse and have trouble sustaining sobriety at home, okay? Then we usually recommend residential treatment. If people are able to sustain sobriety, then usually the decision is, whether or not it's outpatient and how intensive the outpatient treatment is. Some people offer day program. Was not tested really in research for substance use population. Still, people find it helpful. So I think we always hope that most of the treatment is happening in the outpatient level of treatment, because we know that that's where the action is, and that's where people can live their lives. So it's better to do treatment in a more natural environment, because then people can really develop skills how to handle life without substances and with new skills that help them be just more effective at things. So I guess that answers the question.
Yeah. So it leads to a couple more questions. The follow-up question related to this is that if you believe residential treatment is indicated, so let's take those examples where a person's really not able to abstain from substance use, and or their borderline personality disorder is really jeopardizing their safety,
right,
or their ability to participate regularly in treatment.
Right.
So self-injury or a lot of impulsivity. So those would be common reasons residential treatment. Are there any treatment centers that you're aware of, or are there specific centers that have a reputation for having expertise in this area? Because it does seem to be a difficult place to find. So this person really asks that, and I think it's a legitimate question.
It's a legitimate question. I would rather think about this as more like an offline, like a question, because first of all, there are centers in the country that treat patients like this. Number two, it actually depends. Some of them may be better suited for the specific person compared to others. So from that perspective, it may be better done by actually email. I don't know if I can recommend it for that specific person. I go to that particular place, and this will be a good one. There are some places in the country that would do that type of work. I think there's a Life Skills in Florida that certainly specializes in doing DBT. I think that there are some places here that would do that. I think we have at McLean says at Fernside would do that type of work. But those are not the only ones that could really do that type of treatment.
And my guess, even as you're mentioning treatment centers, so there are some treatment centers that are primarily focused on substance use disorders that will also deal with other comorbid disorders. And then there are residential treatment centers that focus on borderline personality disorder, and will also deal with the comorbid disorders that often come with it, including substance abuse, because as you said, more than 50% of BPD patients have a substance use disorder. So I can't imagine that they're turning everyone away.
They not. I think it's a matter of severity. So sometimes people with less severe substance use will be accepted in treatment. More severe, people would say, you need something more than this. But we do have treatment centers like that, so it certainly is available.
Yeah. No, and I want to highlight what you started your answer with, which is the outpatient treatment is probably really where the money is.
More often than not.
And so even if people find a great residential treatment center for 1 or 2 months, that probably isn't going to be the long-term solution, because it might be a good start, but ultimately they're going to have to identify a good outpatient team that will help them figure out how to stay sober, continue using DBT or whatever skills to manage their BPD, and so on and so forth.
Okay. I guess the goal is to help people to be as independent as possible in the community, and independent in terms of their functioning, but also independent of the substances.
Yeah. So I think we have time for maybe one more question. Can you suggest any information on DBT for BPD patients with comorbid substance use disorders? This person specifically is thinking any information for family members, but are there any, you talked about the one study that you found.
Yeah.
Are there any particular good books or resources, websites, anything like that, where people could find out more information about that?
I'm not sure there is a specific book about comorbidity. I think that I don't know if there are if there's something that was written for general public that was written about the comorbidity. I think depending what people want to know, I mean, if people want to understand a little bit more about the treatment itself, you can take a look at the manual and see what's in it. I don't think it was disseminated as sort of as a reading material for the general public. I think it's unfortunate, and I think maybe it highlights the need for something like that to be done.
Yeah.
Yeah.
And so the other thing that I'll plug is our own webinars. So we've actually done a couple of webinars on dialectical behavior therapy, with a broad overview of some of the skill sets, and some of those webinars actually do include other resources on DBT generically, but also probably as it relates to substance use disorders as well. So if the person who asked that question hasn't watched those webinars, I encourage you, it's all free. Go to our resource page and click on one of those webinars and you can view that. So with that, we're going to have to end. So I want to thank you very much, Dr. Weinberg, for a great presentation. I want to let people know that our next webinar is January 25th. We're going to be joined by Dr. John Gunderson, who will be speaking with us on the general psychiatric management model of treatment for borderline personality